Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Supporting Women Impacted by Substance Use, Interpersonal Violence, and Child Welfare Involvement with Worsham L. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and the call in using telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADA's website within 30 business days. To access the recording and PowerPoint, go to www.fada.org, then to our Resource Center, and then to our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADA's website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as a part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development. Completing the evaluation is necessary to receive CE credit or to access a statement of credit. Do note the evaluation will close at midnight on Monday, October 4th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Note that WebEx monitors arrivals and departure of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Worsham L has nearly 15 years of experience empowering diverse populations of vulnerable youth and their families in medical, academic, residential, outpatient, substance use, and child welfare settings. She strongly advocates for promotion of post-traumatic resilience via trauma-informed care. Worsham L is a licensed clinical social worker and certified trauma family professional. She's the co-founder and CEO of Lotus Trauma Care, your Southside Chicago trauma provider. And now I'd like to welcome our presenter, Worsham L. I will turn the presentation over to you.
Peace and good day, everyone. I'm so excited to be here with you all today. So as we begin our morning, I'll begin by just telling you a little bit about who I am, because while I have worked in the fields of substance use, interpersonal violence, and child welfare, this here is more than a career for me. This is actually a passion and a calling of mine. So I want to tell you a little bit about how we arrived here, what to expect this morning as we get into the content. Okay. So when I was about 14 years old, I found myself laying awake at night, experiencing insomnia. And one day I was just staring at the wall where my shoes were lined up. And I found myself asking God why I was walking in the shoes that I was walking in. See, I was flying underneath the radar because I was on honor roll. I had great manners, even though I was dealing with anxiety and depression. And that night, I got the answer that I was supposed to help children or youth like myself. However, at that time, I had absolutely no idea that I would also be helping the inner child of adults to heal as well. So from that point on, I decided to study psychology and with the focus on child and adolescent development, which has really, really contributed to the understanding of the adult manifestations of trauma, especially as they relate to the women we're working with in the field of substance use, child welfare, and interpersonal violence. As I studied at the University of Chicago, I found that trauma or overwhelming stress was the oftentimes not only the perpetuant but also the antecedent for many of the challenges and issues that we found in social services. And so that is where the passion really began, and I began nerding out on neuropsychology and how we can use neurobiology to help to train our brains for a better outcomes, post-traumatic resiliency, how we can help our clients to be empowered, to feel hope again, and to experience peace and joy. For some, this has never happened, but it is so, so important for us to be able to understand how we can empower and inform our clients of the possibility for themselves. So today we'll begin by talking a little bit about the challenges that are faced by women who are impacted by the intersection of substance use, interpersonal violence, and child welfare involvement. Oftentimes, there is a full intersection of these three things, and we'll talk about the barriers to using a trauma-informed approach, as well as the barriers for women who are involved in these programs or fields to be able to complete their substance use treatment as it relates to retaining their children or getting their children back once their child welfare has become involved. In that, we'll recognize and discuss the trauma responses that are experienced by these women who are impacted by this intersection so that we're able to respond with trauma-informed, neurobiologically informed techniques to help support the women in management and reduction of trauma symptoms. We'll talk about many free resources because all too often, one of the biggest challenges in social services is that we don't have the adequate funding or resources to be able to use a lot of the fun interventions or fancy theories and things. So we're going to talk about how to use a polyvagal theory in order to help manipulate the brain for healing, for success, and for resiliency. So as we begin going through this trauma training, it is very, very important that we're aware of ourselves. As we'll learn later on this morning, we are all impacted by trauma or overwhelming stress. And so as we're discussing trauma, as we're discussing working with our clients, naturally, we may have our own experiences or experiences in our professional field pop into our minds and cause our bodies to have some responses. So I want you all to be tasked with an opportunity to practice trauma-informed care by noticing what is happening for you as a professional, because our reactions oftentimes are influencing the interactions that we have with our clients. So I encourage you to be aware of your body and yourself. Specifically, pay attention to your heart rate. If your heart rate is increasing or decreasing, this is an indicator that your stress response system is on. Similarly, pay attention to the tension in your muscles or any physical discomfort. Sometimes you may find that your body wants to move, your leg might be shaking, you might tap, or you're getting some discomfort in your shoulders or your back, and that's totally okay. Again, this is just an indicator that your stress response system is on, something that is naturally going to happen as we discuss trauma and how it shows up in our work. Lastly, pay attention to your thought content. Our mind might take us to the future, might take us to the past, may begin racing. Again, another indicator that our stress response system is on. So if you notice any of these stress responses or many others that might exist for ourselves, I want you to use your breath, another really wonderful free technique of taking longer inhales to help decrease your heart rate. So if you find yourself having a lot more energy, racing thoughts, discomfort, increase in heart rate. If you take longer exhales, it's going to decrease your heart rate and bring you back into what we call your window of tolerance, or basically tapping into our ventral vagal nerve to assist us in remaining present and able to integrate the information that we're learning today. On the opposite end, if you find yourself kind of feeling lethargic, your mind going blank, you want to take longer inhales to take increasing in your heart rate, bringing you back into a ventral vagal nerve, and also practicing this mindful breathing. And it's very important that we would learn more about how important it is to be mindful of our breath and how important it is to be mindful of these body cues, not only for ourselves as professionals, but also in the process of assisting our clients in learning how to do so as well. So we're going to begin by talking about women in trauma and the intersection of substance use, interpersonal violence, and child welfare. Specifically, let's look at some statistics as it relates to the amount of trauma or traumatic experiences that are experienced by our clients. Remembering that when we talk about trauma, we're talking about the body's reaction to overwhelming stress. And we'll talk more about when that overwhelming stress is activated. But trauma is not always a horrific experience, and that's oftentimes what we're thinking. It can be any reaction to overwhelming stress, and overwhelming stress looks different from different individuals. So in 2019 in Florida, 51 to 50% of parents struggled with alcohol and or other drug abuse and or child removal by the state. That's a very large number of parents who are struggling with this intersection here. And so it shows the prevalence and the importance of us being here in this training today to understand how we use trauma-informed care to assist our clients in navigating. Even if we are not working directly with people around parenting or in the child welfare world, oftentimes our clients are parents. Up to 85% of women with a history of substance use have experienced a form of interpersonal violence. 85%, that is an overwhelming large number of women who are experiencing or have experienced some form of interpersonal violence, which we'll learn later has a direct impact on the stress responses, the presentations that they have when we're working with them and supporting them within the field of social services to accomplish whatever goals our program may be accomplishing, rather that be retaining or their child custody, finishing or completing a substance use program, or gaining access to other services such as employment, etc. We have 23 to 82% of women who have experienced childhood sexual abuse. Now, the reason why these numbers have such large variances is because the literature uses different operationalization or basically definitions of sexual abuse and traumas, and so that creates a big range. However, knowing and seeing how large the number gets at 82% of women who may have experienced childhood sexual abuse. This may include incest, molestation, grooming, being exposed to adult sexual content, etc. 10 to 82% of women have reported experience of multiple traumas, with up to 42% of experiencing 5 or more. This is extremely, extremely, extremely important for us to remember that there is a very large likelihood that the clients and the women that we are working with have experienced not only one, but multiple traumas. And the reason why this is so important, as we'll learn a little bit later this afternoon, is understanding that when we have experienced ongoing chronic distress, it causes an automatic or a default response in our stress response system, making it very, very easy for us to go into a trauma or stress response, which is why as professionals, it is extremely imperative that we are aware of how trauma shows up in the presentations of our clients, such as not being able to follow through on goals, having defensiveness, being aggressive verbally or physically, expressing that they don't care or having low motivation. These are all explained as trauma responses, and we'll learn more later on how to understand that and why that is occurring through the lens of the polyvagal theory. 18 to 30% of women have experienced rape, another type of interpersonal violence, but specific in and of itself because of the assault that may happen on a woman, being forced to have some sort of intercourse. And 30 to 75% of women have experienced interpersonal violence or report experiencing interpersonal violence, which is a little different than the other aspect of things, because these are women who, this statistic here is of women who have experienced interpersonal violence alone, whereas the other statistic talked about people or women who have a history of substance use having experienced interpersonal violence. So as we look at this slide here, the purpose of this is to make us understand how significant trauma is for the women that we are working with, how significant it is in the work that we are doing today, to understand that we need to use trauma-informed care to successfully and effectively assist the women we are working with in healing and attaining post-traumatic resiliency in lives that they can feel comfortable with and enjoy. So first we'll look at a study that looked at the barriers to integration of treatment. And they found that 91 to 100% of mothers involved in the child welfare system have experienced at least one traumatic event. And for those of us who are in child welfare or who have worked with the intersection of child welfare or case managers, oftentimes we get access to an integrated assessment, or which is the social history that influences and tells us all about the history of our clients or the parents that we're working with in the child welfare system. And you'll see that oftentimes their lives have been inundated with a lot of overwhelming stressors, whether they be through horrific events or events that are more complex and nuanced. Women of African descent experiences of trauma is exacerbated by historical trauma and racist incidents. They also found that most of the women participating in the study were involved with the child welfare system because they gave birth to an infant exposed to substances. So in understanding what the barriers are to integrated approach. And when we talk about an integrated approach, it's essentially thinking about how do we use a trauma-informed lens within the context of substance use treatment. They found two levels of challenges, one being systemic and one being professional. The systemic level was one of the pieces is the lack of funding, which we are all too familiar with, right? I remember when working in child welfare, I was tasked with providing child therapy with absolutely no child therapy toys, which was completely obscene, right? But the lack of funding can oftentimes be a really big issue that causes an issue in us being able to provide trauma-informed care due to the lack of resources, being able to get professional development for the care, and etc. We also have the lack of preparation for such complex issues accompanying trauma. So in other words, the professionals who are working and paraprofessionals working within this field of substance use, interpersonal violence, and child welfare oftentimes do not have the proper preparation or training to help understand the complexity of the issues that accompany trauma. So instead, we might find ourselves as a case manager, for instance, experiencing a client who is being verbally aggressive and defensive to be resistant or non-cooperative, where really they're experiencing something called a safety threat, which has activated their stress response system, because naturally, how daunting would it be to have someone come in and have the power to take your child from you and to determine whether or not your child is going to be with you? Next, we found that systemically, there was an understanding that there's too much trauma-informed care approach requires too much time and effort as it relates to the allotted time within these programs. Oftentimes, substance use programs are 60, 90 days, 120 days, or have some sort of duration. And the aspect of implementing, or the thought of implementing trauma-informed care into these processes feels like it's too much to accomplish, because we already have all of these tasks that we have to do with our case notes, with our documentation, with the progress monitoring, etc. And it feels as though to add on an additional piece of trauma-informed approach makes it feel a little overwhelming. So when we think about how the next level of challenges are, we come into the professional aspect of things. This is another aspect of barriers which actually intersect and play off of the systemic issues. So the belief that trauma is a secondary priority or a secondary aspect of treatment. as opposed to them being an intersection. So many professionals feel that substance use should be treated first and then the trauma should be treated secondly. Whereas, as we'll learn more throughout this training, oftentimes substance use is a trauma response or a experience or a behavior that is intended to alleviate and ameliorate some of the traumatic experiences such as flashbacks, anger, and many, many other stress responses that occur. The other pieces that professionals found that they believe that individuals they treat can get clean through the same processes that they got treated. When we think about substance use, CADCs, etc., oftentimes many people in some of these programs have not gone into higher level education, and sometimes they have also themselves have experienced substance use and got themselves clean, and in their experience of using the traditional confrontational aspects of treatment, they feel as though because it worked for them, it should also work for their clients. So this leads us into some exacerbated challenges, such as being these systemic issues and professional issues contributing to challenges with adequate compensation and staff retention. We've all worked in settings where there has been a constant turnover, right, in staff, where clients are having multiple case managers within a year, sometimes within a couple of months, etc. And that speaks to the aspect of the challenge and the systemic issue of lack of funding, right? It also contributes to punitive, confrontational, and flexible approaches. So when we have this ideology that our clients are supposed to heal and should heal through one specific model, that can create a very rigid way in which we approach the work that we're doing, sometimes creating punitive, confrontational, and inflexible interactions with our clients, which kind of just create a self-fulfilling prophecy where our clients find themselves defeated or feeling very unmotivated because of the interactions that they're having with the staff or the professional. And so as we talk later on more about trauma and how we use trauma-informed care, we'll learn how to navigate these stress responses that come up as professionals so that we can avoid being punitive, confrontational, and inflexible. And lastly, it contributes to a lack of professional development, honing skills of professionals, right? When we don't have funding, when we don't have buy-in, when we feel like we're pressed for time, it makes it very difficult for us to be able to have the access to the training and the support that's necessary for us to hone the skills necessary to provide trauma-informed care. And today we'll learn how simple trauma-informed care is. It's really not that overwhelming or time consuming as we really think it is. It's often thought to believe. So when we think about the child welfare involvement in substance abuse, the second study we're going to look at is what are the barriers of engagement and completion of treatment for women who are involved in the child welfare system and who have used substances. They found that there were 4 types of expressions, 2 internal and 2 external forms that have influenced the barriers to engagement and completion of treatment. Understanding that the engagement and completion of substance use treatment oftentimes means that their children are no longer in their custody and their rights may be taken away. So we have 35% of the women in this study experienced all 4 forms of expressions, and we'll talk more about these expressions on the next slide. 57% experienced 3 of the expression, and only 8% experienced just 2 of the expressions. So loss of custody is more likely for those with external expressions and or all 4 expressions. And it makes sense because when we have more external expressions, that's being projected at the professional, then a professional naturally will have their own stress responses, which then kind of creates this confrontational, punitive type of interaction that we discussed in the previous slide. So let's look at these 4 areas of expressed challenges before we go into looking at trauma and how to understand how trauma manifests itself in the work that we're doing with our clients. And in this next section, we'll do a lot more interaction where I'll stop talking at you and instead ask you all to kind of engage with the material so that when we leave here today, we feel competent in being able to implement trauma-informed care. So these 4 areas of expressed challenges were again broken down into internal and external experiences. The internal experiences were those of negative self-views. Actually, 92% experienced negative self-views. So this is feeling like I'm a horrible parent. This is feeling like I can't do anything right. and all of these negative thoughts that we'll come to understand as mental safety threats later on once we get into this next section of this training. And these are also the negative self-views or the beliefs that we have about ourselves is another domain that's impacted by childhood trauma. Recalling that a lot of the women that we are working with have a significant history oftentimes of childhood trauma. So even though we may be working with adults, it is extremely imperative for us to understand how childhood trauma does impact us as adults, and especially our functioning and our presentations. 73% experience guilt and shame, another aspect of mental safety threat and social safety threats, where the women are having such significant guilt and shame that they may find themselves using drugs to numb. They might find themselves using drugs to avoid these experiences. And oftentimes that ends up creating drops that are not abstinent of drug use and continue to perpetuate the challenges that they're experiencing, and the ineffectiveness or the inability to complete the program, to get their children back, etc. Other times, these guilt and shame may come from the judgments that they perceive the professionals working with them. Maybe that's the case managers, perhaps it's a substance use counselor, etc. Now, on the contrary, we have some external experiences where 88% experience anger directed towards the provider. And as we go into understanding trauma, we'll come to understand that anger is simply a stress response to safety threats. And in this process, obviously, if we are a professional experiencing a client protecting anger at us, it can have a very significant impact on us. So I'll use an example of working with a woman who in a child welfare field where I was tasked with providing therapy for her in order for her to get her child back. She was also required to take substance use treatment. And as we were discussing her involvement in the child welfare field or the child welfare system, she would oftentimes get very loud or use a lot of profanity, or even sometimes storm out of the office, right? But understanding why she was having these responses helped me to have empathy and compassion to work with her and figure out how to assist her in navigating and regulating those reactions, as opposed to me seeing it and deeming it as her being as uncooperative or unsatisfactory in the completion of her treatment. Now, we have 69% of women who experience a lack of trust in providers, which is why it is so imperative that as professionals, we are mindful of what's coming up for us so that we can show up authentically and genuinely, so that we can create that trust. Because with having trust or a therapeutic relationship, and we don't have to be therapists, right, to have a therapeutic relationship, but it's very important that our clients are able to trust us so that they feel empowered, so that they feel comfortable expressing the barriers and the challenges that are existing, so that we as professionals can help get them the resources that they need in order to navigate those challenges. So now that we have a pretty good understanding of what trauma is a very significant impact on the lives of women who are involved in the child welfare system, using substances and experiencing interpersonal violence, let's understand why understanding trauma is so important. Specifically, how do we recognize and respond to trauma symptoms as they arise? So what I'll need you all to do at this point in time, if possible, is to take out a piece of paper, if you don't already have one, and divide that paper into 4 columns. In each column, you're going to label a different type of safety. Now, what's important to understand is that trauma is a response to a loss of safety, specifically the body's response to a loss of safety. And understanding safety types helps us to understand the triggers and antecedents to our clients' challenges. You also have some worksheets or handouts that summarize this information as well. The loss of safety, these 4 area types that we're talking about, are stemming from the sanctuary model by Sandra Bloom and colleagues, if you'd like to look more into it. So I'm going to explain each one of these safety types to you. And in your columns, I would first like you to consider what these look like for yourself as professionals. Yes, I am intentionally asking you to consider for yourself, what does safety look like for you as a professional within your professional setting, so that before we go into looking at how these safety type or safety threats may look for our clients. So our physical safety is typically the first type of safety that we consider, okay? And in this is basically the integrity of our body. Do we have enough food, shelter, clothing? Am I safe from physical harm? So for instance, this might be that, do I feel safe being in a room? Well, I'll use a case example. When I was working in the field of substance use, I was providing group therapy to adults who were using substances. And in that process, oftentimes there were more men in the room than there were women. And because of my own history of trauma as it relates to men, I would feel a little uncomfortable sometimes when they would get very expressive in what it is that they were saying. And so I had to be mindful of my physical safety so that I did not project my traumas onto them and not document that in a way that was going to be harmful to them. Another example would be when I was working in the field of domestic violence and talking with a parent, another male parent, around how their child got into an argument or how a child was hurt their child. Anyway, in that moment, they felt like myself and another colleague was teaming up on them. So in this very small room, the person got up and kind of was towering over us and using very loud language and words. And in that aspect of time, I felt as though my physical safety was unsafe. That our physical safety was compromised. So these are just some small examples of how physical safety may impact and show up within the realm of professionally. So for yourself in your column, you should have some examples of what physical safety looks like for you and what physical safety threats might look like for yourself. And next, we'll talk about the social safety. The social safety is essentially how comfortable do we feel being ourselves? Can we act like ourselves? Can we speak like ourselves? Can we express our opinions at our meetings? Are we able to dress the way we want to dress? How comfortable and freely can we express ourselves and feel accepted in the process of doing so? So examples of social safety in a professional setting may be whether or not you feel comfortable. So for myself, I am a Muslim woman, and so oftentimes I wrap my hair in a turban. And so when I reverted back to wear my turban, I was working in a hospital setting at that time. And I would oftentimes feel very, very self-conscious about wrapping my turban in professional settings, wondering if others thought that I was being unprofessional or if I was just doing this for style. So this is our social safety. What does social safety look like for you in your column as a professional? Next, we have our moral safety. So this is essentially considering, do our values align with the needs or the actions or what we're seeing? Specifically, am I witnessing something that does not align with my values? Am I doing something that does not align with my values? Do I feel that I have to do something that doesn't align with my values? These would be our moral safety threats. So as social workers in the field of social services, oftentimes we come into this field because we have just watched so many injustices happening to people, and those are moral safety threats, right? Because we're seeing things happen that shouldn't be happening. Within a professional setting, we might find ourselves getting really frustrated about a new policy or a new procedure that has some unintended consequences on our clients and on the treatment process. Those may be more examples of moral safety threats. And next, we have the mental safety threats or psychological safety threats. So we talked a little bit about one of the internal expressions being the guilt, the shame, and the low self-esteem, right? So these are going to be the thought content that's coming up in these women's brains around the situation of being involved in their services, whether it's therapy, substance use treatment, child welfare, or interpersonal violence programs. What is their brain telling them? Is it telling them that they deserved it? Is it telling them that they're never going to change? Is it telling them that they'll never be treated right? How are they assessing the situation? It was my fault. I am the reason for it. So these are our mental safety threats for our clients. But as clinicians, our professionals, sometimes we sit with our clients and we're attempting to support and help them, and it feels like everything we're saying or everything we're doing is just flopping, right? And that might make us feel like a lot of pressure of incompetency. Am I doing enough to help this client? Am I able to help this client? Is this the right field for me? This may be some examples of mental safety threats for yourself as a professional that are pretty common. And so now I ask us all to open up the chat if your device allows and think about what these safety threats may look like for our clients. Consider maybe a challenge that has occurred for your clients, something that has precipitated a behavior or a response that may help to understand the trigger, right? Because safety types or safety threats are essentially the triggers that exist prior to these stress responses that we're seeing with our clientele. So in the chat box, put your example and put what type of safety threat it is that you are witnessing or providing an example for. And while we're all taking a moment to think and type, I'll use an example as it relates to the context that we're speaking on today of social safety. We're dealing with parents. Oh, wait, here we are. Any threat out of the four. Right now, threat of eviction for many of our clients are physical safety threats, most certainly. Physical safety, food insecurity, living in a place where traumatic events occurred. Yes, these are both, or all three of these are wonderful examples of what physical safety threats may look like for our clients, right? Another physical safety, not having food, electricity, and gas being cut off, homelessness, perfect examples. Mental safety threat, past trauma from the medical system, right? So constantly having intrusive thoughts about their past experiences, or thoughts that say that they're going to hurt me, or I can't trust them, or they're trying to exploit me, they're trying to experiment on me. Exactly. These would be some great examples. Different opinions on certain topics. Racism. So different opinions on certain topics could go into the realm of social safety or mental safety or moral safety, depending on how the opinions are being expressed, right? Racism is an example of social safety threats, sometimes moral safety threats, depending on what we're watching happen and play out. These are some really great examples. Do we have any other examples? We have a client was getting verbally aggressive with me during an intake session, and I started to get frustrated as well, naturally. But I decided to take a deep breath and talk calmly. I found out as the conversation continued that the client had a mistrust issue and felt like people were always lying to him. After the meeting, he thanked me for not escalating the situation and said he does have anger issues and knows he needs to work on them. That's a great example of using trauma-informed care, being aware of the stress responses and of yourself. And in that moment, we heard that we had some mental safety threats and some social safety threats. The mental safety threats were telling him that he couldn't trust you, you were lying to him, etc. The social safety of not being respected, not being heard was evident. And in the process of how you responded to him, it created social safety for you all to be able to have a productive conversation. Gender of therapists may be a trigger, most certainly. And in that aspect of things, sometimes we have to do a little bit of exploration, right? So when we think about what these safety threats look like, we may not be right on the nail. However, it gives us an opportunity to further explore these things with our clients so that we can better understand them. Because when our clients feel understood, heard, and validated, I guarantee you it's going to have a very significant positive impact on the work that you're doing, as was provided in the example earlier. A social safety threat example is some clients are guarded from opening up due to family court involvement and fear of them incriminating themselves by opening up. Most certainly, right? So then for ourselves, one of the things we might want to do as clinicians, case managers, social service professionals is be mindful, very mindful of how we're documenting things, right? The language we're using when we're documenting things, and validating that concern and letting our clients know how we protect them on our end. Another example listed here in the chat is I have recently had a client with progressive MS who is wheelchair bound. She has no insurance coverage as her Medicare was denied. She recently was involved in a domestic violence situation with her only caregiver, her spouse, and she is, currently homeless. I cannot think of a safety type that she is not currently experiencing threats and trauma within. Wow, that is a lot for your client to be holding all at once. And I imagine a lot for you to hold for her. And oftentimes, unfortunately, especially when we're working with clients in the fields of substance use, interpersonal violence, there are all of these safety threats constantly being activated, right? So it makes sense why we're seeing aggressive behavior, why we're seeing people shut down, why we're seeing some of the stress responses that we see. Substance abuse stigma can cause individuals to avoid getting treatment. Yep, social safety threats. The possibility of stigma when connecting clients with healthcare professionals who may not understand substance use, another social safety threat. Physical safety. Will he come back even though there is a court order? Will he hurt my child next time? Yes, yes. When the idea or the concern about their child's physical safety, right? So this brings to the point that sometimes these safety threats are about other people. It may not always be about us. It may be about someone we care about. It may be about another human in close proximity. And the question and the thought of will he come back even though there is a court order, etc. Those are kind of exemplifying some mental safety threats. Neonatal unit where nurses thought infants of addicted mothers should be put somewhere else. Yes. So we have, in that aspect of things, we have some moral safety threats where the nurses felt morally that they were doing something right by helping to quote unquote protect these children from their mothers because of their own judgments that were happening, right? There's some social safety where the mothers are being judged in that aspect of things. The physical safety for the nurses' fear of the infant's health. Psychological. See, many abused children respond poorly to physical characteristics of treatment providers that are similar to those of the people who abuse them. Yes. And so as we talk more about trauma, we'll definitely understand how and why something like a facial expression or physical characteristics can be triggering, right? So what's happening is that our brains, when we're experiencing chronic overwhelming stress, the process called bilateral integration is not happening, meaning that the hippocampus, which is where our long-term memory is stored, is bypassed and it goes directly to the amygdala, which is only picking up those things that tell us that there's a threat. So the next time we see something like the color, the physical characteristic, the sound, the word, the smell, etc., our brain is able to respond even quicker to keep us safe from that traumatic experience of reoccurring. So that kind of helps just to kind of provide some context as to why that happens for the children. We have moral safety threats, acknowledgement of infidelity during marital counseling. Yes, yes. It's something very, very significant for us to be aware of as clinicians. How do we feel about these things, right? And then how is it showing up in the work that we're doing with our clients? I'll read two more examples and then we'll continue on. I had a client trying to leave her husband. However, her religion does not believe in divorce, and she was worried about being shamed by the church for leaving. Social safety, mental safety. So anytime I asked about housing, she would get very defensive because she felt I did not understand the religious aspects of this. That social safety. I find that my individuals who have child welfare involvement tend to be much more standoffish to sharing, even after I share about confidentiality and explain my note taking. So in those moments, we're kind of jumping ahead a little bit, in those moments of dealing with those sort of challenges, what we want to do is use validation and to kind of just help to create that social safety and create that trust. And as in the process of being consistent and in being empathetic and in validating their experiences, they will begin to open up and honoring that it makes sense that you don't want to share this. And is there something that you don't want on record, right? Versus those things that you have to put on record, kind of helping to give them options and be helpful. All right. So these are all wonderful, wonderful examples. There's a lot more here, but for the interest of time, I do want to continue. We'll be taking a break in about 15 minutes. So these are all really great examples of what safety threat types or safety threats may look like for our clients. Again, remembering that when we see these things, right, are occurring, when we see a potential safety threat, this gives us an opportunity as a professional to explore the triggers, okay, and help to understand contextually why our client is responding the way they're responding and how to support them in navigating the barriers. Two, it gives us an opportunity to create that therapeutic alliance and that rapport and that safety, that social safety, which is going to be the platform for the empowerment and the hope and the progress that we want to see within our clients. So these are wonderful, wonderful, wonderful examples. Thank you all so much for your participation. Now we're going to talk a little bit about the stress responses, because after we have a safety threat that activates us. We will then go into stress responses. And in many of your examples, you spoke about the different stress responses that come up. So let's look at how we can understand these a little bit more. Again, using the polyvagal theory and understanding of the autonomic nervous system, specifically the parasympathetic and the sympathetic branches of the autonomic nervous system. So we'll begin by watching a video before I explain these. So while we're waiting for the video to get pulled up, I'm going to ask us all to again take our paper out, maybe on the back of the paper, at the bottom of the paper. Perhaps you want to use a new piece. And we're going to divide your columns into 4 again. And label your columns fight, flight, freeze, and fawn. We'll come back to that instruction as we watch this video about how toxic stress in childhood can derail healthy development, recalling the significant statistics that we heard earlier during this training around the childhood experiences of trauma and how this has impacted the presentations that we see with our clients today, be it the substance use, the aggression, the lack of participation, etc. Wonderful. So this video does an excellent example or job of illustrating how our neural pathways are impacted by the experiences of overwhelming stress. It talks about it within the context of children, but who here was never a child, right? Even when working with adults, did they skip over childhood? Absolutely not. Our childhood has a direct impact on how we show up in the world, how we feel about ourselves, how we respond to stress, how we manage emotions, etc. So it's very, very important that we have an understanding of our client's history with childhood trauma as it so that it can inform the understanding and the conceptualization of the presentation that they're showing up with in the present moment. Similarly, one of the things that's really important to note in there is that we are talking about fewer and weaker neural pathways. It does not mean that they do not have the capacity to regulate. It does not mean that they're doomed, right? What it means is that it's going to require us as professionals to prioritize helping our clients to regulate before we can really see some of those higher functioning aspects of things. So again, it gives us the opportunity to have realistic expectations of our clients as well as of the work that we're doing with our clients. Similarly, this information gives us the understanding and the ability to advocate for our clients in our case notes, right? So yes, there may have been these stress responses that occurred. Maybe they behaved in an aggressive manner due to a traumatic historical trigger, right? So we're able to advocate and to explain and conceptualize in a way that offers compassion and in a way that does not recreate the traumatic experience in a way that allows for our clients to have post-traumatic resiliency being implemented and being nurtured. So on your paper, you should have 4 columns. And in those 4 columns, you should have 1 column labeled the fight response, 1 column labeled the flight response. The other 2 columns are labeled freeze and the other fawn. So fight, flight, freeze, and fawn. So again, I'm going to ask you all to consider for yourself what this looks like as professionals, because again, we are humans and we are naturally going to have responses to our clients having their own stress responses. And then we'll take a moment to jump back into the chat box and talk about some more contextualized examples of what the stress responses may look like within practice and in the field for our clients. So in the stress, what happens with the stress response system? I want to say first that having our clients or having our own stress response system activated in and of itself does not mean something is wrong. Our goal is not to avoid triggering our clients. That is impossible. And that is an unrealistic expectation. Instead, our goal is to understand the human stress responses so that when we see it within ourselves, our clients, our colleagues, our family, or any human, we're able to respond in a realistic manner to help them to regulate so that we can get the accomplished goal met. So when we experience a stress response system, we will initially oftentimes go into what we call the sympathetic response branch of the autonomic nervous system. The sympathetic branch is responsible for the fight and flight responses. The fight response is responsible for fighting off a threat, right? Recalling that these threats can be sounds, sensations, emotions, thoughts, physical characteristics, almost any internal and external stimuli that has been paired with the client's past experiences of being overwhelmed or being unsafe. Okay, so again, the stress response system can be activated by any internal or external stimuli because of the way the brain has processed the past and experience with that particular stimuli. Okay, so kind of thinking about some classical conditioning here. So in the fight response, this might look like us having verbal aggression. This might look like physical aggression. This may look like racing thoughts. This may look like anxiety. This may look like not ADHD, not being able to sit still or to concentrate, right? As professionals, our fight responses may look like quitting a job. It may look like us closing a case out because we keep getting met with what we deem as resistance. Okay, whereas our flight response comes up when we identify that there's absolutely nothing we can do, right? But it's things that we can actually get away from and we can avoid it. So this might look like procrastination. This may look like avoiding conversation. This may look like avoiding places. This may look like avoiding people. This may look like avoiding situations. This may look like any behavior that is intended to avoid the stimuli. Okay, whereas the fight response is any behavior that is intended to fight off that fight response. But what's more important for you as opposed to is it a fight or flight response is understanding when you see someone in their sympathetic branch, right? So think about high energy. What energy is, there's a lot of energy being pushed towards this safety threat, either real or perceived, because our brain has neural pathways that light up regardless if the thing is actually physically happening or not, right? Which is why visualization is so important, which is why we have to be empathetic and compassionate towards our fellow humans, our clients, when they're experiencing or expressing a stress response or a safety threat in some shape or form, okay? So the sympathetic branch is responsible for the fight and flight responses that are high energy, that look like high energy. Now, let's say what goes up has to come back down, right? So when we're up, we're anxious, our brain is racing, I'm constantly fighting, we're naturally going to get exhausted at some point, right? Or we may find ourselves in a situation where I have fought so many times in the past that I no longer believe that there's anything I can do. And we will find ourselves in the freeze and fawn responses. Now, this is responsible, the freeze and fawn response are responsible are actually not responsible, but are activated by the dorsal vagal nerve. And this is when we're seeing depression, right? let me break it up. So freeze response, you might see the mind going blank. You might see them staring off into space. We might see a lot of daydreaming, disassociation. So the freeze response is when our body kind of just freezes and our minds and body freezes because it does not feel or assume that there's nothing that can be done in that moment, right? This is often common for people who have experienced sexual abuse, etc. Then we have, severe interpersonal violence, such as physical abuse and things of that nature. And then we have the fawn response. The fawn response is more of a surrender type of thing, right? Where it's like, okay, people pleasing. I don't have the energy to keep telling you no or to set boundaries, so sure, I'll do it. The fawn response may look like internalizing or like the Stockholm syndrome, where I'm aligning with the abuser or with the person who is abusing me or harming me, right? So these are the freeze and fawn responses. Again, it's not necessarily super important to be able to say it's a freeze or it's a fawn, but it's there to recognize when a dorsal vagal nerve is activated, meaning that there is a low energy and there's a lack of action that is actually occurring in that moment. Okay. Now, in addition to the freeze and fawn response, the parasympathetic branch is also responsible for the ventral vagal nerve, which is the part of the automatic nervous system that is like an off switch to the sympathetic and the dorsal vagal nerve, right? So naturally, when we are experiencing, let's say I'm walking through the city and I'm walking across the street and there's a bus coming, naturally this stress response system needs to come on so that I can react fast enough in milliseconds to keep myself safe. Once the threat has subsided, the ventral vagal nerve will then turn on and cut off the activation of the sympathetic and parasympathetic response, stress responses specifically. When that happens, that person is being pulled into what we call the window of tolerance. And our jobs as professionals is to manipulate this ventral vagal nerve and to help our clients to activate the ventral vagal nerve so that they can have healthy resolution of these stress responses when they're being activated. Because what happens is when we're chronically activated, oftentimes all throughout our lives for a number of different reasons, these stress responses will come on within nine times faster than our prefrontal cortex, where we're able to assess that the situation is not really threatening in that moment. Okay, so we are attempting to manipulate the ventral vagal nerve, and we're going to talk more about how to do that by recognizing when the stress response system is on. So now that we've taken a moment to look at what these fight, flight, freeze, and fawn responses look like as professionals, let's drop in the box what they might look like for clients. And while we are thinking, I'll give an example of a fight response in a professional setting. And working in a domestic violence or interpersonal violence field, there was so much stress that when I would pull up to the gate, literally my adrenaline will begin rushing. That was an example of a fight response, my body preparing itself for the threats of the moral safety threats and all the different threats that come up in that setting, right? Similarly, I might have had in another setting in a hospital working around providing trauma therapy. In our weekly meetings, staff meetings, I would have a stomach ache every Wednesday right before it. It was a fight response again. Now, why is this happening? Why do we have these physical ailments and things that are paired with our stress responses? It's because the automatic nervous system is also responsible for our digestive system, our respiratory system, our immune system, and our reproductive system, etc. These major systems that are responsible for our survival. So this is why there's a mind-body connection. This is why the ACEs study, or the Adverse Childhood Study, has found a very high correlation between trauma and physical health. Let's go into this chat box and see what examples we have. I would like for you to put what type of stress response it is and an example of your client's responses. The majority of our clients are in the state of fight and flight constantly due to the stress levels coming at them from multiple areas: environmental, health, family, fear, addictions, etc. And all of these impact the client's ability to process messages and respond appropriately. Most certainly. So what that means is that within our work with our clients, we want to create safety, create a moment of calm so that they do have an opportunity to be in their ventral vagal nerve so they can process messages, so that they can identify an appropriate response, right? And in the process of even helping them, so in that, creating that safe space, Or A, creating new neural pathways of having an access to a pathway of being regulated so that we can do these things. But then B, we're also helping to prepare them for how they're going to respond to these stress responses and safety threats in the field or out in the world in their lives. An example of fight response would be a client leaving in the middle of a session. Yes, 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 yes. I've had clients storm out of my office and mental safety threats to the professional. What did I do wrong? But understanding that she needed help regulating. Working with those young adults who are aging out of foster care system, they are consistently in fight. They are consistently in. I'm assuming they're consistently in a fight and fight responses for sure. And then we have flight, leaving AMA. I'm not sure what AMA is. And it was constantly in survival mode. Avoidance to individual therapy due to anxiety related to fear of sharing, fear of reliving painful experiences, or fear of confronting, processing uncomfortable emotions. Exactly, those definitely some flight responses. Parasympathetic response. The parasympathetic response is a freeze and fawn response or the regulation. So not sure what the example is being given. Some of our clients are numb to the effects of their childhood trauma and don't want to talk about any of it. So that would definitely be a parasympathetic response, that freeze and fawn response that's been shut down and disassociated from because it's too overwhelming. That I think we've all probably heard coming up that your brain will protect you from the things that you really can't process or deal with, right? So oftentimes that we might have clients who have no idea, they can't tell you about their childhood. They don't remember, right? Or they don't recall it. And it's actually real that they don't recall it because of the way in which the brain has stored it away. Seeing clients stare off into space with an open question that was triggering. One client did not realize they were doing it, had not recognized the time that passed. Sat peacefully and quietly with them and waiting for response. Then validating and reassuring, okay, to take time and take a few loud, deep breaths. Against medical or clinical advice. So behaving against medical or clinical advice can be some fight or flight responses for sure. Frozen when someone gets loud, definitely a freeze response. I would imagine that there might have been some interpersonal or physical abuse present. AMA is against medical advice. Thank you, Angela. Just learned something new today. AMA, so against the medical advice might be okay, everyone's helping me with that. I appreciate you guys. One of my clients who had experienced physical and sexual abuse described herself as being, quote unquote, too nice. She further clarified that she thought that if she wasn't nice to men trying to talk to her, they would hurt her or her family or little sister. So those are those fawn responses, right? Surrender. I'm going to surrender before you have the opportunity to hurt me. Did you label mine fight or flight? Sorry, I missed that. Let me see, Sierra. Let me go up real quick and see what you dropped in. Avoidance of individual therapy due to anxiety related, that would be a flight response. We're avoiding reliving these experiences. We're avoiding confronting and processing uncomfortable emotions. So that would be a flight response. Yeah. Tanisha says fights, verbal aggression and profanity when DCM report false information to court resulting in decreased visitation with children. Yes, definitely verbal aggression, profanity, fight response. Like, this is not okay, right? Who wouldn't get upset when something like that would happen? You're barely seeing your child once a week, if that. Modeling and informing on regulation is very important. They may not have a good role model for sure. Thank you, Christopher. It's very, very important that we are demonstrating those things, right? We're humans too. And in the process of having a dialogue where emotions run high and we're demonstrating how to remain within our regulatory window, it's going to definitely help to provide an example of it being possible. May have had a bad role model. Flight, clients using substances to escape from stressors. Yep. Important to discuss brain function with victims of domestic violence. Running away from the situation, flight, have probably saved their lives. Exactly, right? So what Rebecca's mentioning here is the importance of validating and normalizing that your brain did exactly what it needed to do to protect you and to keep you alive, right? These stress responses are all about survival. The brain's number one priority is survival. It doesn't care about how much money we make, what position we have, where we live, and all these materialistic things that we're really focused on in society today. The number one point for the brain is survival, which is why these stress response systems and safety threats are so imperative for us as professionals to be aware of, because anytime there is a safety threat, the stress response system will show up. And if we don't see the stress response as a reaction to a safety threat, then we have the power to ruin lives. We have the power to do something such as have someone's visitation being removed. We have the power to have someone be closed out from substance use treatment because of a natural stress response, right? And so these things are very, very important in helping us to conceptualize and understand how it's going to be the most effective way to respond to our clients. Instead, we have freeze, failure to follow up with referral for needed services, PT due to feeling overwhelmed with case plan tasks. Yes, great example, Tanisha. So in that moment, when we're noticing that's kind of what's happening, right, with understanding and having a trauma-informed lens, is the client being non-resistant and uncooperative, or do we help them to break down the task? Do we offer to, do some of the work with them, right? How can we then approach that situation to assist in the process of accomplishing the task that we need them to accomplish? Another example is that we had a client who tended to react with a freeze and flight response whenever she felt overwhelmed or crowded. We once lost her in the shelter and found her hiding in a corner behind a couch, zoned out, napping. When she came to, she told us that she felt useless and powerless in her life. So there's some mental safety threats there. There's definitely a flight response and a freeze response for sure. Sleeping, oversleeping, is another example of those dorsal vagal or freeze responses. Clients should video any interaction to have proof. Fight response. Yep. Trying to fight off any potential challenges and things. Flight response, a client constantly reliving a trauma from their past as a way to validate their behaviors, and in turn avoiding talking about said trauma. So the reliving aspect of things, I think it's more of a fight response, the intrusive thoughts, etc. And definitely avoiding talking about it is a fight response, because the experience of reliving it has been so overwhelming that they no longer have the energy or the capacity to tolerate the discussion, right? So they're out of their window of tolerance. The other freeze response, clients is provided supports and services, but is so shut down that they don't take the next steps to apply those supports or attend services, overwhelmed by their compounded negative experiences. And so understanding that when we give these service plans, we give like, okay, you have to do this, like 100 different things they have to do, right? On top of the social safety threat of am I a bad parent? On top of the moral safety threat of did I hurt my child? What did I do? How have I harmed my child, right? There are so many safety threats that are going on. So perhaps being mindful of how we can help to titrate the steps that are being taken with our clients, right? Maybe we can make the phone call together. Maybe if possible, if it permits, we can help take them to those appointments and provide them with the support so that they're able to experience a regulated, or at least some experience of doing these services within their window of tolerance, so that they are able to then have a neural pathway of success, so that the next time it comes around, oh, there was a time where it wasn't so overwhelming that I had to shut down and not do it. These are all really great examples. And we're going to go ahead and take a break. We're supposed to take a break at 11. So I want to allow us all a moment to take a break. And then we will go into discussing a little bit more about how trauma impacts our clients' abilities, the higher functioning prefrontal cortex abilities. And then lastly, how we actually implement trauma-informed care and what we can do to help empower our clients, empower our staff, and any humans that we're interacting with. Thank you all for your participation. We'll see you in 5 minutes.
Thank you all. We're going to meet back here at 11:13. Thank you. Hello, everyone. Welcome back to today's webinar. Worsham, if you are ready, we'll turn the presentation back over to you.
Awesome. Thank you, Rebecca. Appreciate you. So I just want to clarify a couple of questions here before we move on with the presentation to help clarify fight, freeze, and flight responses. So the fight response are those behaviors that are intended to fight off the internal or external stimuli that has been perceived as a safety threat, right? So that might, sometimes that is disorganization, sometimes that is having trouble recalling information because our brain is really processing things so fast that it's really disorganized at this point in time. We have a freeze response, which is more or less having no energy or motivation to respond to this safety threat that's been perceived because, or real safety threat, because of the nature of the threat. So the freeze response is exactly as it sounds. So there is a lack of reaction to what's happening, right? But it's outside of our control. So we have procrastination. We're doing that in a flight response, right? We're avoiding, whereas a freeze response would be like, I'm asleep all the time. I'm lethargic. I don't have low motivation. So I hope that makes sense and kind of like the teasing those apart. But what's most important is just recognizing when we have the high energy, the fight and flight versus the low energy, the freeze and fawn, because that tells us if we're in a sympathetic or the parasympathetic branch. And when we're in the parasympathetic branch where that freeze and fawn response, we are going to we're not going to do things that require a lot of activity, right? We're going to make smaller steps because there's already a lot less energy. Whereas in a fight and flight response or that high energy response, we're going to use responses such as exercise or doing things that are going to help get that energy out. Right. So that's the reason why we kind of have those two apart. And I also want to just note that with the sympathetic fight and flight responses, things like pain, inflammation, poor concentration, etc., those are also fight and flight responses because of the way in which the brain is over processing everything. Okay. Anxiety, another sympathetic branch response. Okay. Any other questions on clarifying what these stress responses look like before we continue? Excellent. So far, what we know is that women who are experiencing the intersection of interpersonal violence, child welfare, and substance use oftentimes have a very high prevalence of experiences of overwhelming stress or trauma. And their trauma has created a lot of safety threats, real or perceived, that are easily activated and may show up as stress responses in the work that we have with them. So understanding their childhood trauma, understanding the impact of trauma on the human brain, on the human's ability to be present, allows for us as professionals to have realistic expectations so that we can minimize our own frustrations in the work that we're doing, but also in the process of empowering our clients to be able to have successes and feel good about the ability to take back control over their lives. Wrong way. Direction. All right, so we're going to review a couple of different types of trauma. Okay, now most important on this slide is the frequency and the duration of the stress. Okay, we talked about understanding trauma as the experience, the body's reactions to a loss of safety. Okay, we're going to talk about different categories of trauma, and they range from intensity and frequency and duration. And so when we're sitting with our clients, understanding that when we have a higher frequency and a higher duration, there are going to be stronger stress responses and much stronger triggers in the neural pathways because of the process of myelination that occurs in the brain. Whereas when there is fewer intense enduring experiences of chronic stress, there is going to be less or fewer safety threats, right? There might be, or I guess we just not fewer safety threats per se, but there's going to be, the treatment process is going to be a little simpler than it would be with someone who has such complex experiences of enduring safety threats. And when we think about the social, political, or racial context that we're dealing with right now, unfortunately, there are constantly safety threats happening all the time for many of the people we work with. 9 times out of 10, the people that we are working with within social services are of non-European descent and do have a lot of these safety threats that come with just being the social safety of being judged and criticized and these negative myths because of their phenotypes or their physical characteristics. So that's something to also be mindful of. So in beginning with acute trauma is when there is a single incident that has both a start and end date, right? So there was a medical surgery that maybe happened, or a car accident, or a car fire, or a house fire, right? There was a start and an end date. It was traumatic in and of itself because of the overwhelming stress that it may have caused. However, there was an end date, whereas chronic trauma is repeated and prolonged and does not have a start and end date. It's enduring, right? So some examples would be interpersonal violence. It would be homelessness, may be another example. We have a medical illness, a chronic medical illness. These are awesome examples of repeated and prolonged chronic traumas because it does not have a clear-cut start and end date, but instead just is an ongoing aspect of chronic stress or chronic activation of this autonomic nervous system. Whereas we have complex trauma, it's like combination of chronic and acute trauma. This exposure to varied and multiple traumatic events that are often invasive and interpersonal in nature. So when we think about the clients that we're working with, the women we're working with that are involved in child welfare system and interpersonal violence and substance use, oftentimes they have experienced complex trauma where it's very difficult sometimes to pinpoint what specific event or experience was the cause of the trigger, but instead it's the overall schema or belief system that has been created from the experience of these multiple and very traumatic events that have occurred. So some examples of complex trauma may include having a parent who's abusing substances. It may include experiencing a combination of maybe it was myself, for example. We had a house fire. I had parents who abused substances, and there was domestic violence in the home, right? So there's a chronic and acute trauma all mixed up in there, right? Sexual abuse all mixed up in there. So there's so many different complexities of trauma that have occurred that it's all kind of balled up into this big old ball, and it's very difficult to pinpoint the nuances of what's coming up. But instead, the big picture is that all of these experiences may have created some sort of belief system or schema, right, that has impacted the way that we navigate the world. The next type we'll talk about is developmental trauma, which is addition of the COVID impact. Yes, COVID is definitely a chronic trauma at this point. We do not know when it's going to end. It is the experience, and it may even be complex because some people are experiencing grief while experiencing homelessness, while experiencing access to food, right? So it could be both chronic and complex. And so what's important is that we are exploring with our clients what their experiences have been. But COVID definitely falls, and this pandemic definitely falls within the trauma realm of things because of all of the safety threats that are present within this pandemic. Developmental trauma are those experiences of trauma prior to the age of 6, often interpersonal in nature. And the reason why it has its own specific category is because our first 2 years of lives, and especially our first 6 years of life is extremely imperative for our higher level functioning, such as inhibition, self-esteem, interpersonal skills, emotional regulation, etc. And so when we experience trauma prior to 6 years old, especially prior to 2 years old, what we end up seeing is a lot stronger myelinated processes, or essentially a lot stronger stress responses, such as distrust, a lot stronger challenges we're going to talk more about the different domains in just a moment, but a lot stronger belief systems that are protective in nature because of the distrust and the impact of how having chronic stress from a caregiver or someone who is supposed to protect you and guide you can be really confusing, right? Because now I love this person, I'm supposed to feel safe with this person, but I don't. So just envisioning the impact and the confusion that has on one's ability to navigate the world. Can I trust people? No, I wasn't able to trust my parents or my caregivers. How can I possibly trust other people, right? So developmental trauma is experiences of trauma prior to the age of 6, experience of overwhelming stress prior to the age of 6. If you have a question, let me see here. Can developmental trauma be a child being born into a family of drug addicts and as a result neglected and placed into yes, 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 most certainly, right? There was even some prenatal, more than likely there was some either just like in the womb, there was experiencing some trauma, coming out experiencing some trauma because of the dysfunction. Now what happens with developmental trauma is because it's all we've ever known, right? We don't recognize it as trauma. That makes sense. And so because it's all our clients may have ever known is dysfunction, is being overwhelmed, is having activation of the stress response system, it's just the norm. And we may not recognize it as trauma. In fact, we may find that the baseline of functioning is already overwhelmed, right? Where I'm already overwhelmed at my baseline, so the little things can kind of set me off or seem to set me off because I'm already on the edge of my window of tolerance. It was a great question. Intergenerational trauma. This is the transmission of post-traumatic stress symptoms and adaptations to our offspring. So if we were to say, for instance, the distrust of the medical system within the Moorish community or those that are known as African American community, right? Because of experiments such as the Tuskegee experiment and many of the inhumane experiments that have been done on this group of people, there is a distrust that is passed down to their offspring, right? Or even sometimes the way in which family members may talk to each other, the way in which they deal with emotions, do they shut them down and they're not to express it? These are some other ways that intergenerational trauma can be expressed. So what happens is that the stress responses are showing up not because of the child's or the person's lived experiences, but because of how they were socialized. We are implementing the use of ACEs in our home visiting programs at the health department. Do you think this is a good assessment? We are here in Pinellas County have a staff trained in trauma-informed care. That's awesome that all of your staff are trained. That's definitely one of the first steps to trauma-informed care. And yes, I do believe using ACEs is a good first step to assessing the trauma that has occurred. Because when you see numbers 4 and higher, it just tells you that safety is going to be even more important. And it also informs the conceptualization of why you're seeing the challenges and the barriers that you're seeing within your clientele. Excellent question. And then lastly, we'll talk about historical trauma, which is the post-colonial distress following colonization of indigenous people by European settlers and the subsequent inequities and disparities. So historical trauma has 4 different components. It's a concept that was created back in the late 80s, early 90s that explained the inequities and disparities. And in that process, it kind of perpetuates a lot of the challenges and things that we're seeing. So this might look like policies and procedures, such as the Jim Crow laws, the war against drugs, right? The taking of indigenous peoples and putting them into indigenous children and putting into boarding schools. These are some examples of historical trauma. The mass incarceration, the school to prison pipeline, more examples of historical trauma. So again, when we think about the different trauma types, what we are focused on is the intensity, the frequency, and the duration, because that helps us to understand and conceptualize why the individual we're sitting across from is reacting in the way they're reacting, why they see the world the way they see the world. And it gives us an opportunity to provide realistic expectations and the resources that they need in order to navigate these experiences. So we're validating their experiences. It makes sense that you would feel that way. It makes sense that you would respond this way. It's been helpful in the past, right? So that's what's important. But for a moment, because we've been talking a lot about chronic trauma and what trauma looks like, I want to take a moment to walk us through a relaxation exercise. Because when we think about trauma, we're thinking about the intensity, the duration, and what our clients have experienced, it naturally activates our own bodies. And it's really important that we're able to recognize when this happens. So this is a 2-minute exercise that you can use with yourself as well as with your clients that can help us to come back into that ventral vagal nerve, which is the part of the parasympathetic system that helps with regulation, right? Where we're able to be intimate, where we're relaxed, where we're able to be our best selves, where we have joy and peace. So I'm going to explain it to you first. What we're going to do is first make sure we're breathing in our bellies, okay? And that means that when we inhale, our belly should be rising, like a filling with air. And when we exhale, our belly should be falling, going back towards our spine. We're going to maintain this breath, and then I'm going to ask that you drop. You can choose which shoulder and ear you want to start with, but you're going to drop your right, just for an example, I'll use your right ear to your right shoulder, leaving your shoulder relaxed. Just going to drop your right ear to your right shoulder, and you're going to look at your shoulder or your elbow crease, whichever gaze feels comfortable. We're going to hold that gaze for 45 seconds. You may do 60 seconds, and if you want, when you're doing it yourself, we'll lift our heads and we'll do it onto the other side. Remembering that the breath and the eye gaze are very, very important in pulling us back into this ventral vagal nerve. So because I'm a nerd and I think this is really cool, before we begin, I want you to take a nice neck roll. And just notice any discomfort, any tightness that you might experience as you give your neck a nice roll. And after we're done with this exercise, we will then do another neck roll and you'll see the difference. It's like almost as though your neck has been lubricated. Okay. So taking a deep breath in through our nose, getting comfortable in our chairs, breathing in for 1, 2, 3, 4. Exhale. 2, 3, 4. Returning your breath to a natural pace, your belly rising with each inhale and falling with each exhale. Choosing whichever ear you like to begin with, please drop your ear down to your shoulder and place your gaze on your shoulder or elbow crease. Holding your gaze and maintaining your breath for a count of 45. 8, 9, 10, 11, 12, 13, 14, 15. Returning your attention to your breath or your gaze. Just noticing the thoughts. 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33. Bringing your attention back to your breath. 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45. Lifting your head and dropping your opposite ear to the same shoulder there. You started with your right, dropping your left to your left shoulder. Placing your gaze, maintaining your breath for a count of 1, 2, 3, 4, 5, 6, 7, 8, 9. Redirecting your attention to your breath or my voice. 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, maintaining your breath, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45. Taking a deep breath in through your nose, and out through your mouth, giving your neck a nice roll. Noticing the difference from that first roll, experiencing any comfort in your body. Your body needs to move, allow it to do so, trusting it. Thank you all for your participation. That exercise is called the half salamander. Okay, there was a question in the chat asking, is racism intergenerational? Yes, when we're teaching children through our own comments, our own responses to people that don't look like us, we are definitely teaching racism. And unfortunately, by the age of 2, children pick up on it. Okay, so chronic stress, right? Trauma is the experience of overwhelming chronic stress. Now, what's important is to understand that the stress response system being activated in and of itself does not mean there's something wrong, right? Because there is such thing called positive and tolerable level of stresses. Okay, so when we have a positive level of stress, it's something that's like motivating us to get up to go to work or motivating us to do something that we enjoy, right? And what happens is that once the threat has left or it's a manageable threat, the ventral vagal nerve from the parasympathetic branch turn it off, and we continue on with our day. Then we have those tolerable levels, right? We have temporary things going on, such as life transitions. Maybe we're planning a wedding, we're planning a funeral, but it may be tolerable at that point because we have supportive relationships, and those relationships pull us into the ventral vagal nerve, right? One of the very, 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 very best 3 interventions is our therapeutic relationship or supportive relationship that we have with our clients, significantly supported by literature as well as by lived experience of all of us humans, right? And then we have toxic stress, which is what we're talking about, the prolonged activation of the stress response system in absence of protective relationships and those other mediating things such as activities and hobbies and expressive outlets. So when we're experiencing an activation of the stress response system, we will oftentimes experience something called dysregulated functioning, right, versus the regulated functioning. So when we're regulated or within our positive or tolerable level of stress, we're able to process the world and the environment in a way where we can observe what's happening. So let's say, for instance, that we were inside of the room together during this training, and I'll see someone pick up a pen to write a note. I'll observe that they picked up a pen, and I may interpret that they're writing notes and process that they're not about to stab me with that pen. So I can either continue or I can ask them to put the pen down. I'm going to continue speaking, and I'll continue speaking. Whereas if I were just regulated or experiencing more of a toxic level of stress response at that moment, I may observe if they're picking up the pen, interpret that they're picking it up so that they can stab me, and act by lunging at this individual to stop them from trying to stab me with that pen. Okay. Very dramatic, right? However, to illustrate the point, when we're dysregulated, we don't process the world in a very congruent manner because the thalamus has bypassed the hippocampus and the other parts of the brain that really evaluate things so that we can act. Okay, and it hits the amygdala, which is responsible for that fight, flight, freeze, and fawn response. So this is why it is so important that when we recognize that our clients are not in the tolerable level of stress or a positive level of stress, that we're not trying to give them a whole bunch of tasks to do at that point in time, right? That we are not attempting to provide insights and criticisms or explore too much at that point in time because we don't have access fully to our prefrontal cortex, right? It's inhibited at that time. And the prefrontal cortex is 9 times slower in milliseconds than the automatic nervous system or the limbic part of the brain that we're talking about and manipulating when we're working with trauma. So when trauma is chronic and overwhelming or toxic stress, it impacts 7 domains, okay? And this literature is looking at the 7 domains of childhood trauma. Nonetheless, because the automatic nervous system is the same throughout life, with the exception of the first 2 years when it's really developing, if you have a chronic expression, you're going to end up seeing these 7 domains being impacted. The first being biology or our health, right? We see a lot of heart disease, we see a lot of strokes, we see a lot of inflammation and things of that nature because, again, the automatic nervous system is not only responsible for our stress responses, but also responsible for our physical health, the immune system, the respiratory system, the reproductive system, and other major systems that we need in order to survive. And then we have our cognition or our thought. When we think back earlier to the internal barriers that the literature found around women having with challenges of completing their substance use treatment, shame and guilt and low self-esteem, those are thoughts, right? Beliefs that they have that impact their ability to make decisions that are aligned with their values and their true goals. And then we have attachment, right? The relationships that we have. Do I trust people? Do I interact with people? Do I communicate effectively with people? What are the quality of the interactions and the relationships that I have? And if I've had trauma at a very, very young age, such as developmental trauma, we will definitely see an impact in our attachment. Sometimes this looks like overly attaching to people. Sometimes it looks like just shutting off from attaching to people. Sometimes it looks like poor boundaries with people. Sometimes it looks like not, so it can look very different for different people. There's no one size fits all sort of thing, but what's important is understanding that these are the domains that may be impacted. And when we know that there has been a history of trauma, be it in adulthood or childhood, then we know that there's going to be likely some sort of impact that has occurred. Now, if we have a client who has childhood trauma, and 9 times out of 10 we will, then we know it's going to exacerbate these different domains, right? Meaning that our stress, us being aware of the stress responses and attuned to those stress responses and helping to create safety is going to be imperative for the effectiveness of our services and the interventions that we use within our organizations. Another impacted domain is the ability to regulate emotions, right? Sometimes you may have restricted affect where I don't show happiness, I don't show kindness. I'm always saying I don't care. I'm very nonchalant because my emotions or my ability to be in touch with these emotions has kind of been dampened through the dorsal vagal nerve because it's overwhelming and I don't have the capacity to deal with. So it's more of a freeze-fall response to the affect. Other times you may see someone exploding, right, where they go off, where they're throwing things, they're cussing people out, etc., because it's challenging of regulating emotionally. Substance use is another issue, another challenge or behavior that is often used to help to deal with emotion regulation. Then we have disassociation. Disassociation is very, very common within developmental trauma, sexual abuse, interpersonal violence, physical abuse, especially that experience in childhood. But in those moments where you feel completely helpless for whatever reason, be it because of the context of that you're in or because of the timing of the trauma itself, disassociation may occur where we're really disconnected from our experience and from what's happening in order for it to become tolerable so that we're able to survive in that moment, right? So that's disassociation. Then we have the behavioral control where I may not be, similarly to the impulse control, but may not be able to stop myself from lunging and choking you when you jump at me or make a facial expression, or I may not be able to sit still in class or in this program or in this group, or I may not be able to not blurt out something when I'm talking in group therapy because someone said something that aligned with me or that really resonated. And then we have our self-concept, right? Going again back to those internal experiences. Can I do this? Am I good enough? Do I deserve this? What am I a piece of crap? Am I worthy? Am I valuable, right? The self-concept is significantly impacted when we have experienced complex trauma, developmental trauma, and those more intense, enduring traumas. Because the world and the experiences have taught us, if we don't have those supportive relationships, that we are not worthy in one way or another. So now that we have looked at what trauma is and we understand that trauma is the body's reaction to safety threats, rather real or perceived, and that understanding these safety threats gives us the opportunity to provide realistic expectations, to understand our clients' triggers, to be able to conceptualize what's happening. Let's talk about how we can respond to it when we see it. Right? Because we're all sitting here because we have a belief and we have a hope that we can help people move past this. And oftentimes we have stories where we have seen it move, have seen people move past these experiences of trauma. So there is an overwhelming literature, right? And then also I'm sure your lived experiences and professional experiences that there is a need for an integrated approach of substance use and trauma-informed care, right? Trauma-informed care within the child welfare system, within the domestic violence system, and within the substance use systems, right? And especially when we're talking about all of the intersection of these systems, we definitely need an integrated approach, meaning we're using trauma-informed lens. Why? Because it guides the understanding of the presentation as trauma responses, right? We just talked about how it's the difference between us seeing someone as being uncooperative versus seeing someone being overwhelmed. right? It gives us the ability to respond in a compassionate way, in a way that does not recreate the trauma that they've experienced where people are doubting them and shutting down on them. We have trauma being experienced by women also impacts their mental health, their interpersonal relationships, and their parenting, right? So we cannot support women in an effective manner if we're ignoring trauma that is impacting all of these areas that we're trying to target. We also want to use trauma-informed care in the field of substance abuse because it's been supported by over 20 years of literature. And these integrated programs, I think it's very important to know that they're less likely to be used in Midwestern, South, and Western regions of the USA, and that the research illustrates the need and effectiveness of trauma-informed care and trauma-focused strategies to treat substance use. I'll tell you, I actually left working at a substance use treatment center because I was so frustrated with the inability to target the trauma because of the model that was being used within the organization I was working in, because it became very, very apparent, even more so than intuition, that these people that I was working with that were using substances to cope with their trauma. Substance use is a trauma response 9 times out of 10. As is physical abuse and abusing our children, as it relates to the child welfare system. So what does trauma-informed care in practice look like? How is it helpful for us? Why is it something that we want to use? We want to use it because the recognition of these stress responses may impair the ability to engage women and have success with interventions and programs, right? So if we don't recognize that the stress response is showing up, we're going to miss an opportunity to help promote post-traumatic resiliency. We're going to miss an opportunity to support our clients, and instead we're going to respond in those punitive, confrontational, ineffective ways because of our own stress responses that we're unaware of. It also helps to guide implementation of adaptations and selection of our interventions, right? People are different. There's nuances all across the board. There is no one lived experience, right? But what is important is that we all have this automatic nervous system, and when we're recognizing the stress responses, we're able to then make small adaptations to the work that we're doing within our organization so that we're able to promote post-traumatic resiliency, so that we're able to help our clients to be successful in accomplishing whatever the goal may be within their program. It also helps to guide an understanding of our presentation, the symptomology, and the behavior of the women that we're working with, the humans that we're interacting with. It provides predictability and choices to be offered to enhance the sense of safety and control for women, right? So it may be that you have a whole bunch, like child welfare, for instance, you have a whole bunch of paperwork, unrealistic amount of paperwork to be done within 45 days, but in creating some type of sense of control, would you like to do this paperwork first or that paperwork first, right? And explaining what the purpose of each of these papers are for, the consent, the integrated assessment, etc., the safety assessment, all the wonderful things, but giving them as many choices as possible, even when there's like a choice that's controlled by the circumstances of the structure of the program. And it also assists professionals in managing vicarious trauma and burnout, because we then recognize that we as humans are also going to be subject to having our own stress responses when our clients have stress responses, but also when we're seeing all these moral safety threats and all these threats that our clients are experiencing on a day-to-day. And when we're aware of our own stuff, right, how our own histories or our clients' histories are impacting us, that gives us the capacity to have realistic expectations for ourselves when you need to take a break, when you need to calm your body and your mind so that you can respond in an appropriate manner. So let's talk about some trauma-informed approaches and what this looks like, right? We're going to look at SAMHSA's approach because it's a universal approach that allows the concept to be used across systems, right? We have 4 components. 1, realizing the widespread impact and pathways for recovery. No human is exempt from trauma because every human has an automatic nervous system and every human will be triggered by stress responses, okay? And that understanding that no human is exempt from it, it allows us the ability to recognize the signs of trauma for all the people involved in whatever system we're working within, right? This information is not only relevant to the work we do in our professional world, but the work when we're at home with our spouses, with our children, with our family members and community members, and just interacting with humans in general. It also allows us to respond with the integration of knowledge of traumas in order to resist re-traumatization, right? Resisting re-traumatization is our active goal of everybody involved in the system, from the secretary to the maintenance guy on up to the CEO. No one is exempt from having this lens when we're thinking about creating a trauma-informed organization. And there are 6 core principles that are extremely important, being safety. Safety, 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 because if a person does not feel safe, their stress response system will come on. And all of these goals that we have where we're requiring people to use their prefrontal cortex is unrealistic and just creates all sort of frustrations for everyone involved. Peer support of our staff, of our helping our clients to make sure that they have healthy relationships, working together. These are extremely important in the process of trauma-informed care, because we recognize that human relationships are a wonderful free way for us to tap into that ventral vagal nerve and to promote post-traumatic resiliency. It also requires empowerment, voice, and choice, trustworthy and transparency, collaboration and mutuality, and cultural, historical, and gender issues. So these things are being targeted in the way in which we're doing our work. So I'm going to skip this a little bit so we can talk more specifically about some concrete steps and things that we can do, as we only have 10 minutes. 5 simple steps that you can take to implement trauma-informed care. Number 1, which we practiced earlier today, is to notice your own stress responses and current distress levels, right? That is the reason why I had us think about, as professionals, what do our safety threats look like? What are our stress responses looking like? A couple of examples earlier gave and pointed out that they were frustrated or that they were having reactions. And it's very important that we're aware of these things so that we can accurately go to step 2 and assess for the safety threats and stress responses of the women that we're working with. Only after we address and assess the safety threats and stress responses can we choose an effective intervention and implement that intervention. And then we'll repeat steps as necessary. The interventions that I'm going to express to you today are free interventions where it does not require your organization to go buy anything, where you're using your individual self as a healing agent. You are so important in the healing process of your clients by just being genuine, authentic people. When I train students, when I train professionals, I always hammer in that you are your most important tool in intervention. So one thing you can do is to help your client to ground. Grounding is the process of using our 5 senses, right? You want to get a cup of water. Do you see this on the wall? Or you might use an actual fun little exercise that you can look up online where you use 5 things you see, 4 things you hear, 3 things you feel, 2 things you smell, 1 thing you taste, right? We're also going to use that relationship. Okay, using active listening, reflecting what we hear a person saying, I'm trying to understand their thoughts, their emotions. We're going to validate their experiences, validate what they're thinking. It makes sense why you dislike, this system. It makes sense why you don't trust the system, excuse me. Right? So validating does not mean that we are not, we're in agreement with the behavior or that we're in agreement on what happened, but validation instead acknowledges that it makes sense in the context of their lived experiences, right? Whereas active listening is demonstrating to that person that we're here and present with them and listening, and not just on our own agendas as professionals or the organization that we represent. We also want to affirm our clients, affirm their values, affirm their efforts, affirm the progress as much as possible, because all too often, as we saw earlier, low self-esteem, shame, and guilt are really big barriers to implementing or successfully completing programs, and really big issue that the women we're working with, they find themselves experiencing. So again, not only affirming their strengths, but their values, their intentions, their progress, right? Affirming their being, their personhood, right? Their strength, etc. Using I statements is also really important for modeling the effective communication and effective interpersonal skills, but it also can be really great in setting boundaries, because you're humans too. No one wants to be screamed at or yelled at, no matter how much I understand why you're experiencing, right? So in the time with your clients, you may use something called I and statements or validation and statements where you are validating what you're hearing. I hear what you're saying and I'm listening. Can you please lower your voice? Right? So I want to use a case example. Try to be conscious of time, but also want to make sure this makes sense. So when I was working with that young woman that I kind of expressed earlier, who would get really activated when we talked about her involvement with the stress response system, the first day I called her and told her, hi, my name is Worsham, I'm your assigned therapist. She started screaming at me, okay? And in that process, I validated what I heard her saying and asked her and let her know that I was listening. Okay. And in that process, her voice came down and we were able to have a regular conversation. And the reason why she was screaming is because she didn't feel heard half the time, right? Because of the unfortunate manner of which she came into the system, whereby the nurses thought that she was being uncooperative, etc., because she was fearful for her child's life and her life after having just been stabbed by her paramour. We want to use open-ended questions. Open-ended questions are great ways to show that you're curious about your client. Open-ended questions are great ways for you to understand the reasoning behind your clients, what's important to your clients, which will then guide you in being able to help motivate them to reach their goals and do the things they need to do. Those open-ended questions are going to begin with what, when, where, why, how, right? But remembering that if they're a little overwhelmed, if they're out of their window of tolerance, open-ended questions may be too difficult. We want to use more closed and yes or no questions. Or even just having a moment for our clients to breathe, right, and ground themselves. So before we continue on with those larger tasks we have to do within our programs. Explaining the process is so important. Right? I literally would tell my clients, I'm going to close the door now. I'm going over here to this drawer to get this out, right? So I'm explaining why I'm moving, where I'm going, what's happening, what there is to expect. We're going to do the assessment, today's appointment. We're going to do this paperwork because of this, and this. So explaining and creating some type of predictability of the process is going to help to create safety so that we don't have to have all these mental safety threats around what are they going to do? Are they going to use, how they're going to use this information, etc. When we think about all of that historical trauma, the intergenerational trauma, and the potential experiences and schemas that our clients have as it relates to interacting with helping professionals. Asking for permission, right? Again, creating safety. Again, especially when we think about when we consider trauma, interpersonal trauma, which was predominantly the type of trauma that our clients were experiencing per the literature. Asking permission is helping them to reestablish their boundaries and empower them and let them know that their voices matter, right? So you may ask permission such as, is it okay if I come sit over next to you, right? And you may ask permission such as, is it okay if I come in? May I use your bathroom if you're doing home visits? Just asking permission just shows mutual respect as opposed to walking around in our authority and assuming that we can do and be whoever we want because we have the authority to make a decision on this person's life. It also helps to reduce some of that power differential so that we can collaborate with our clients as well. Yes, it sure is, Christopher. Offer options. Offering options is so important. And again, another aspect of being able to empower our clients, giving them a voice, letting them know we respect them, right? By offering options, you want to do this form first or that form first? What would you like to focus on today? Is there something that you have pressing today, right? Offering options as little as you can. You want to use the black pen or the red pen, the black pen or the blue pen. There are no options that are too small, especially because all too often no one's ever asked what it is that this person wants or what they believe, etc. And then lastly, make sure you're assessing trauma history and or their triggers, right? Because understanding their trauma history, understanding their triggers is going to help you understand them as a person. And when they feel understood and valued as a person, you guys are going to get so much further in the process of your program, whatever service it is that you're providing to your clients. So we have about 4 minutes left. So instead of doing the case study, I want to open the floor for any questions to make sure that when we leave this training today, we feel confident in our ability to implement trauma-informed care, namely recognizing the stress responses, the safety threats, and using our interpersonal strategies to help implement safety. Will we be getting copies of slides? Also, I hope a recording will be available. I had to miss a part of this great presentation. Thank you, Vicki. I believe so. I do know that the training will be up within the next 30 days at the FATA's website. And the presentation slides, I'm not sure, Rebecca, do they have access to the slides?
Yes, the slides will be on our website as well, and they are in the chat right now for everyone as well.
Awesome. Thank you so much. Christopher says it is so important to give our patients the same respect that we desire. Seriously, 100% Christopher. Just questions about CE certificate. Yes, there you have an evaluation to complete, and there will be the email coming out that prompts you to do all of that and how to receive that. Sierra says great training. Thank you. Thank you, Sierra. I'm really glad that everyone has gotten the information that they needed out of this training. I hope that you feel empowered to go out and change the world, right? One person at a time. Your interaction with the person is a domino effect. We are humans, and our conditions are based on how we treat each other. So thank you so much for all your participation and for your commitment to trauma-informed care. It's been a pleasure being here with you all this morning.
Well, thank you very much, Worsham. We really appreciate it.
My pleasure.
And unfortunately, that is all the time we have for today. We have included Worsham L's contact information so that you may contact her with any further questions. Worsham L, we really thank you for all the work you put into this webinar and all the valuable information you shared today. Please note a couple of items of business before we conclude. Please see the chat panel for a link to today's survey. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FATA's website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. If you can, register as a visitor at no cost. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You need to use the same email address when you registered for our webinars through our WebEx link and when you set up your profile in FATA's system. This connects your attendance with your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The sender will be messenger@webex.com. The evaluation will close at midnight, Monday, October 4th, 2021. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and especially thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day and please hold for the evaluation.